titled Low-Risk MDS and Non-Transplant Therapies. Thank you for joining us. My name is Nyari Sireo, Patient and Professional Program Coordinator, and I will be moderating the presentation today. As we get started, we recognize the generosity of our corporate sponsors and the generous support of patients, families, and caregivers for supporting the conference today. Following the MDS presentations, there will be a question and answer session. If you are participating online, please feel free to submit questions at any time during the presentation from the Q&A icon on the engagement panel on your right. To submit a question or comment, type your question in the Q&A text box window, and when you have finished typing your question, hit enter. We will do our best to get to all the questions. When asking questions, I respectfully ask that you do two things to help me manage the incoming questions. First, submit your entire question at the same time. Second, please do not share private health information in your question. Our speaker cannot answer any specific questions related to your healthcare. Today's specialist is Vijaya Bhatt. Dr. Bhatt is an associate professor and medical director of the leukemia program in the Division of Hematology and Oncology, Department of Internal Medicine. He is board certified in internal medicine, hematology, and oncology. He has also completed a Master of Science in Clinical and Translational Research. He manages patients with acute leukemia, myeloid malignancies, and other hematologic disorders, and those who have undergone stem cell transplant. He finds great joy in interacting with his patients and working in a multidisciplinary team to support patients through the course of their treatment. With that said, please welcome Dr. Bhatt.
Thank you so much. Let me see if slides are moving good. Perfect. I hope you are enjoying your Saturday morning, whether in person here or at home. I'm going to talk about low-risk myelodysplastic syndrome. So what I thought I'd start with is some basic information about blood, bone marrow, myelodysplastic syndrome, and then I'll discuss about management options. So inside bones, we have bone marrow, which is soft material, and bone marrow is what makes blood cells. There are many different types of blood cells, which we'll talk about. So we have red blood cells, we have platelet, and then we have white blood cells, which there are different subtypes of white blood cells, neutrophil, lymphocytes, and so on. So red blood cells carry oxygen. If your red blood cells or hemoglobin goes down, we call it anemia. If your platelet count goes down, we call it thrombocytopenia. Platelet count prevents bleeding. And then white blood cell count fights infection. When the white blood cell count goes down, we call it leukopenia. And then if the neutrophil count goes down, we call it neutropenia. So myelodysplastic syndrome, MDS, myelo refers to bone marrow. Dysplastic indicates that the cells in the bone marrow or blood do not look normal, they look dysplastic. And syndrome often refers to collection of several different symptoms and abnormalities. So essentially, MDS means that the bone marrow is not working well, and it's causing low blood count and other problems. Myelodysplastic syndrome is generally underreported. Sometimes it's not diagnosed. Many people may have low blood count, which is mild, and a bone marrow biopsy is not necessary and not done. So it's felt that MDS is underdiagnosed and underreported. But the reported incidence of MDS is about 14,000 new cases per year. MDS is quite uncommon in people under the age of 40 or 50 years. It can be diagnosed, including in children, but it's uncommon. The most common age group is 60 to 80 or so. The median age of diagnosis is often in 70s. And it's slightly more common in men. What causes MDS? Most of the time, we cannot pinpoint as to this is what somebody did or did not do that led to MDS. As I said, it's much more common in people after the age of 50, 60 years. That's a common risk factor. Benzene is one of the chemicals that is associated with higher risk of myelodysplastic syndrome. Benzene is found in several things, including automobile exhaust, industrial emissions, and smoking cigarette also exposes people to low level of benzene over a longer period of time. In patients who develop what's called a treatment-related myelodysplastic syndrome, prior exposure to chemotherapy or radiation plays a role. In the past, it was felt that chemotherapy and radiation are the only factors that cause therapy-related MDS. Now we know that people who are diagnosed with a cancer and then get chemotherapy and radiation and develop MDS, if you go back and look, some of these mutation or genetic changes that are seen in MDS are actually found in some people before they get chemotherapy and radiation. So chemotherapy and radiation can increase the risk of treatment-related MDS, but that may not be the only reason why people get treatment-related MDS. It is also recommended that people who get more than one type of cancer should see a genetic counselor to determine whether there is a mutation or genetic defect they are born with. MDS in general, in adult, it's not familial, and cancer is not contagious. That means that family members or friends are not going to get MDS just because you have MDS. Diagnosis of MDS, people often are found to have low blood count. Sometimes that happens because people have symptoms. Sometimes that happens because you need a surgery and a routine blood count is done that shows low blood count, and that leads to further evaluation. Once low blood counts are detected, oftentimes people would be referred to a hematologist. They would do a bone marrow biopsy and other tests. If there are dysplastic cells or blast, that raises the suspicion of MDS or other hematologic malignancies. That leads to a bone marrow biopsy, and bone marrow biopsy can confirm the diagnosis of myelodysplastic syndrome. What are the symptoms of MDS? It depends upon what's going on with the blood counts. If hemoglobin is low, people have anemia that often causes fatigue, tiredness, difficulty breathing, depending upon how low hemoglobin is. Hemoglobin that is, let's say, slightly low may not necessarily cause any symptoms, but if it is significantly low, it certainly can cause those symptoms. If the hemoglobin is very low, people would also require blood transfusions. Low platelet count can increase the risk of bleeding or bruising, and if it is very low, you may also require platelet transfusion. And then low neutrophil count or white blood cells increases the risk of infection. So when we do a bone marrow biopsy to confirm the diagnosis of MDS, we look at a few things. One is how many cells are there. So we look at whether there are excess amount of cells, normal amount of cells, or less than normal amount of cells. That gives an idea about what's going on, and I'll talk a little bit more about that. And then whether the cells look normal or abnormal. So we look at dysplastic cells, and then we look at blast. Blast or myeloblast, generally a healthy adult has 1 to 2% blast in the bone marrow. When we do certain tests like immunohistochemistry or flow cytometry that looks at a protein on the surface of the blast, if those blasts are not cancer, those would appear normal. If they are cancer, then the expression of protein on the surface would be abnormal. So that gives an idea about whether it's a healthy blast or mother cells that leads to formation of different kind of myeloid cells, or it is a cancer blast and raises concern about MDS or acute leukemia. Generally speaking, if the blast count is less than 20%, that it's not acute leukemia, except in some situation. So bone marrow biopsy, this picture shows the process of bone marrow biopsy. We insert a needle to take out a piece of bone along with the soft material inside the bone called bone marrow. Then we make slides from those specimens. Those slides are sent to pathologists to review under microscope. So that's one of the important tests. And then under the microscope, this is how it looks like. So we look at different type of cells, the shape of the cells, the shape of the nucleus inside the cells. If it looks normal, as we would expect in a healthy person, then that's not dysplastic. If the cells look abnormal, there are several patterns, then the pathologist would say that there are abnormalities or dysplasia. So I refer to blast. So myeloblast gives rise to all these different type of cells, and through different stages, you get normal, healthy neutrophils that fight infection. So blast, oftentimes when you are seeing a cancer doctor, when we are talking about blast, we often say blast is equivalent to cancer, but that is the case if the blast is abnormal and looks like cancer based on those tests, including the appearance of blast under the microscope, some of the stains and flow cytometry can tell whether the blast is normal or cancer. But in general, some physicians may not talk in that way, and oftentimes in the setting of MDS or cancer, when we say blast, we are referring to a cancer blast and not a normal, healthy-looking blast. So in the typical changes in bone marrow in someone with MDS include excess amount of cells. Vast majority of patients with myelodysplastic syndrome have excess amount of cells. However, a subset of patients with MDS can have less than normal amount of cells as well. But the classical finding is increased cellularity. And then we would see abnormal cells or dysplastic cells. Excess amount of blast may be seen depending upon the type of MDS. And most of the patients with MDS will have genetic changes, which I'll talk about in a second. So inside a human cell, there is nucleus. Inside the nucleus, there are pairs of chromosomes, and in those chromosomes, there are genes. So humans' normal cells has 23 pairs of chromosomes or 46 chromosomes. Men have XY chromosome and women have XX sex chromosome. These genes in these chromosomes determine the color of hair and things of that nature. So various characteristics of the person is determined by these genes. So in cancer setting, MDS and other cancer, there are abnormalities of various different types in the chromosomes in individual genes. So if there is an extra there could be extra chromosome, loss of a chromosome, a part of the chromosome may be deleted, a part of a chromosome can move from one chromosome to another chromosome. So you could have all these abnormalities that are detected by standard karyotyping. And then genes, there could be specific change in a particular gene, which is what we call mutation. And these genetic and mutation changes do not necessarily reflect that the cancer runs in the family or things of that nature. These changes are changes because of MDS. Now, MDS is a very broad group of cancers in the sense that some patients with MDS have low-risk MDS or low-grade MDS that does not have excess blast. At times, there may not be genetic changes or even mutations. On the other hand, some patients have MDS that may behave even like acute leukemia. In patients who don't have excess number of blasts or low-grade MDS, it can be very difficult to say whether it's MDS or whether it is something else. So in low-grade MDS, it's very important to make sure that we have ruled out other causes of dysplasia or low blood count. So some of these causes of low blood count and possibly dysplasia include nutritional deficiency. So deficiency in B12, folic acid, copper can cause low blood count and can even result in abnormal cells in the blood and bone marrow. So it's very important to rule out those causes. Chemotherapy, certain drugs can cause low blood count. When the bone marrow is recovering from either chemotherapy or even other kind of illness, it's common to see dysplasia type of changes, so the cells don't always look normal. If there is certain conditions that lead to breakdown of blood cell or hemolysis, and then following the recovery from hemolysis, the bone marrow is recovering and trying to compensate and make more red blood cells. When you do a bone marrow biopsy in that situation, it's also common to see abnormalities in the red blood cells. That does not always mean that it's MDS, so ruling out those conditions are important. Now, MDS and aplastic anemia are two different diseases, and as I said, most of the time MDS has excess number of cells in bone marrow, but a subset of patients with MDS can have low number of cells in the bone marrow. So these patients have what we call hypoplastic MDS. In that situation, it's important to rule out aplastic anemia, which is not a cancer. MDS is a cancer. Aplastic anemia generally does not have those dysplastic changes and is not always associated with genetic or mutation abnormalities, although those can be present. So you have to be thoughtful about the possibility of aplastic anemia versus hypoplastic MDS. Differentiating those two conditions are not always easy, but you certainly have to think about the possibility. So low-grade MDS can be very difficult to diagnose because there could be other conditions that can mimic low-grade MDS. So their expertise of the hematopathologist makes a lot of difference. If there is a lot of dysplasia, that can support MDS, but again, you have to rule out other conditions. If there is excess blast, that certainly helps to confirm the diagnosis. If there are genetic changes or mutation changes, that certainly helps as well. In some situations, you have to wait and see if the blood counts improve over time. Let's say someone is admitted in ICU with sepsis or other serious conditions, the blood count don't look good. If they get a bone marrow biopsy in the hospital, it's not uncommon at all that there could be some abnormal type of cells. But if you wait and a month or two later the blood counts improve, then it is likely not MDS. It is because of what was going on during the hospital stay. So sometimes you have to wait and see if the blood counts improve or not. MDS diagnosis requires that the blood count is persistently low for at least a few months, oftentimes more than 3 or 4 months. So let's say we make a diagnosis of MDS. It's a blood cancer or bone marrow cancer, so there is no staging. In some way, it's involving multiple parts of body, unlike a solid cancer where It can be diagnosed when it is localized to an organ, and then if it spreads elsewhere, you call it stage 4. MDS, it's when it gets diagnosed, it's involving multiple parts of bone marrow throughout the body. There may be cancer cells circulating in the blood. So there is no staging in MDS. But there are certain factors that determine outcome. So those include blood counts. If there are involvement of more than one type of blood cells, and the extent of cytopenias make influence outcomes. So that's one factor. Excess amount of blast count generally is not a good thing, so that's the second thing. And one of the most important factor is the nature of MDS, or genetic changes and mutation changes in MDS. So until recently, we used to utilize what's called a Revised International Prognostic Scoring System, or IPSS, and it took into consideration blood counts, blast, and genetic changes mostly, and it divided people into very low risk, low, intermediate, high, and very high risk. And the outcome was very different. If someone had very low risk, their median survival was 9 years, and many of these patients, if they are doing well, don't even need treatment. On the other hand, if someone has very high risk MDS, the survival can be very low. More recently, mutations were integrated in these scoring system. So currently there is a newer classification called molecular IPSS, which is better than the older classification. It certainly influences or can predict the risk of developing leukemia, risk of survival, or chances of survival, and so on. Here are some of the mutations that influence survival. Mutations in MDS in general is not a good thing, except for SF3B1 alpha mutation, which is associated with good prognosis, and also predicts a better response to a drug called luspatercept, which we'll talk in a second. So molecular IPSS compared to the revised IPSS improves prognostication. So we are able to tell more accurately the estimated survival and outcome with molecular IPSS compared to revised IPSS. Some of the other factors beyond what's in the molecular IPSS that A, influence outcome, B, also influence treatment tolerance, include prior exposure to chemotherapy or radiation. If someone has treatment-related MDS, in general, the prognosis is a little bit worse. It's important to consider family history of cancer, and if there are multiple family members with cancer, particularly in younger age, meaning less than 50 or 60 years, then it's important to think about genetic counseling. And then patients' overall health, including other health problem, fitness, that makes a difference in terms of outcome as well as treatment tolerance. Now, when we think about MDS, why do people don't do well? Oftentimes, people feel that that's because of leukemia. The reason I have this slide is that's not necessarily the case all the time. You can see that many people don't survive because of completely unrelated causes, or stroke or cardiovascular complication, which are quite common. In part because MDS is most commonly diagnosed as someone in their 60s, 70s, and 80s. People have other health problems, including hypertension, diabetes. They may have prior history of heart problems, so they are at risk of cardiovascular complication. So good care for someone with MDS also involves taking care of those other health problems and not just trying to prevent leukemia, which is even more important for someone who has low-grade MDS, where the risk of developing leukemia is less. And then depending upon the blood count, if platelet count is low, there is risk of bleeding. If the white count is low, there's risk of infection. So now I'm going to talk about the management of low-grade MDS. So when we think about managing MDS, first we have to look at the big picture and determine what's the goal of care in MDS. In low-grade MDS, the goal is to improve quality of life. In high-grade MDS or high-risk MDS, there obviously in any situation our goal is to improve quality of life, but there we are also trying to improve survival and decrease the risk of leukemia, because if not adequately treated, high-risk MDS can transform to leukemia, and very high-risk MDS, the survival is very short. So it's important to utilize treatment that can extend survival and also possibly offer some chances of cure. So in low-risk MDS patient who, let's say, are in their 70s and they have slightly low blood count, they are feeling well, and they are not requiring transfusion, you don't have to treat them. You can monitor them. So very low risk, and possibly intermediate risk MDS in the past, we would monitor them. If they progress, if they require, if their blood count goes down, they are developing symptoms from anemia and things of that nature, or they are requiring transfusion, then they would need treatment. Otherwise, we could monitor. And some patients with low risk MDS can do very well for a period of time without having any complication or possibly even symptoms. In patients who have anemia, depending upon how low the anemia is, we would consider treatment for anemia. If it is very low, then we do red blood cell transfusion. The threshold for transfusing red blood cell is less than 7, or in people who have heart problem or other risk factors, less than 8. In MDS, there are studies looking at could a different threshold improve quality of life and things of that nature, but in general, this is the threshold that is utilized. If someone has a lot of symptoms and their hemoglobin is 7.5, we may still transfuse even if they don't have heart problems because of the symptoms. The risk of bleeding is substantially high when the platelet count is less than 10,000. So that's the usual threshold for platelet transfusion. Obviously, if someone is bleeding, we would transfuse regardless of whether it's 10,000, 15,000, or 20,000. If someone has other kind of serious bleeding, let's say bleeding from bowels, then we generally want to maintain platelet count even higher than that, as high as 50,000 or so. And in case of trauma or anything else that causes brain bleeding, our threshold is, if possible, maintain platelet at 100,000, at least in the beginning. But generally speaking, if the platelet count is, say, 30, 40, 50,000 or more, spontaneous bleeding is quite uncommon. Bleeding is much more common if it is less than 10,000. And some people don't necessarily bleed if their platelet count is less than 10,000 for a day or two. Low blood count is a little bit tricky to manage. There are not a lot of good treatment when someone has low white blood cell count. Antibiotics can be considered, but there are not high quality studies that have shown that antibiotic makes a difference. If someone is getting chemotherapy or things of that nature, these are the antibiotics we use in acute myeloid leukemia. In acute myeloid leukemia, there are clinical trials, including in some situation randomized clinical trial. But in MDS, there are no good clinical trials that have established antibiotic as a standard of care. So on a case-by-case basis, some of these could be considered, particularly for someone who is getting chemotherapy. But for low-risk MDS patient who is not getting chemotherapy, who is feeling well, the role of antibiotic is not clear. On the other hand, vaccines are important, whether it's COVID-19 vaccine with the current COVID pandemic, influenza vaccine, vaccine for shingles, pneumococcal vaccine, and so on. Those are important. In patients who have received a lot of blood transfusion where the iron levels or ferritin is very high, medication to decrease iron overload is helpful based on the anticipated outcome. Exercise, healthy lifestyle, management of other health problem is super important, particularly in low-risk MDS, in part because, as I said earlier, cardiovascular complication is a big problem in patients with low-grade MDS. So controlling cardiovascular risk factor, and if someone has stroke or heart attack, managing them optimally is super important. What are some of the medications to treat anemia? Anemia is one of the biggest problem in low-grade MDS. Can cause fatigue, symptoms, not feeling well, low energy. People don't want to do a whole lot of things. And then anemia is one of the most common cytopenias in MDS. So what can we do? So there are a few medicines. One group of medicine stimulates bone marrow to make blood cells. So there are a couple of those drugs, epoetin and darbepoetin. Those have been used for a while now. They are most effective if a person is not requiring a lot of blood transfusion. This is a hormone that is made by kidneys. So in patients with chronic kidney disease, this is commonly used. So if this hormone level is low, then we know that they benefit more. So if the transfusion need is less than 2 a month, 2 units of red blood cell a month, or if the erythropoietin level is less than 500, the chances of response is higher. The lower the level of erythropoietin, probably the higher the chances. So that's one option. More recently, the other medication option that is available is luspatercept. There are a couple of things that correlate response to this drug, which includes the ringed sideroblast as well as SF3B1 mutation. Both of these group of drugs, the common risk associated with their use is hypertension and clots. The risk of clot involves both venous blood clot, like let's say lower leg deep vein thrombosis, as well as slightly higher risk of heart attack, stroke, and things of that nature. Again, that emphasizes why it is so important to control cardiovascular risk factor in patients with MDS. So this is a trial that supports the use of luspatercept. Overall, it's relatively easy drug to tolerate, does have minor side effect, and both this medicine as well as erythropoiesis stimulating agents have a response rate of 40% or so. The other treatment for anemia is a oral pill called lenalidomide. Both of the other drug were shots. This is an oral pill. Lenalidomide is an oral pill. It's an oral chemotherapy, which is most effective in patients with a specific subset of MDS called MDS with 5q deleted syndrome, which often presents with predominantly macrocytic anemia. The platelet count and other counts are relatively normal. It's classically more common in women, but certainly can happen in men as well. And then if you have low risk MDS with 5q deletion, then this drug works quite well. The response rate can be seen in 2 out of 3 people, and the response can last for a while. But although it's an oral pill, it is still a chemotherapy and can have various different type of side effects, including low blood count, fatigue, infection risk, and several others. But in that particular situation, it can work very well. Now, some of the other treatment that can be useful in select patients with low-risk MDS include ATG, or anti-thymocyte globulin. This is a immunosuppressive medicine. It is useful in patients with low-grade MDS or lower-risk MDS. There are several different factors that have been inconsistently associated with response, which include low-risk MDS that most of the studies support, lower cell count, small PNH clone, HLA-DR. Those are some of the factors that correlate with response. So that's one option. The other treatment option in patients with lower platelet count is just like medicine that stimulates red blood cell. There are medicines that stimulate platelet. So medicine like romiplastim or L-Trombopac stimulate bone marrow to make more platelet. So those medications can be used. There is a small concern that these drugs can stimulate blast count. We certainly do not recommend using them if the blast count is high. But if the blast count is low and we are trying to improve quality of life, then that could offer an option. And then Dr. Dhakal is going to talk more about chemotherapy or transplant, but in situation where other treatments have not worked, there are chemotherapy options that can be considered on a case-by-case basis for low-risk MDS. In low-risk MDS, sometimes a shorter duration of chemotherapy can also be associated with improvement in blood count and higher quality of life. Transplant is generally not recommended for low-risk MDS. It's mostly reserved for high-risk MDS. So in conclusion, MDS is a blood cancer. Sometimes it's called as pre-leukemia or blood disorder or whatnot, but scientifically it is a blood cancer. Now, it is not always serious. Some patients can do quite well for a long period of time. On the other hand, it can be as serious as acute leukemia if it is a very high-risk MDS. Blood counts, low blood count causes symptoms including fatigue, infection, bleeding, and things of that nature. There is a higher risk of developing leukemia, particularly in higher risk MDS, but a lot of people do have complication as a result of cardiovascular complication and other health problems. The goals of care is different. In patients with low-risk MDS, our goal is to improve their quality of life, decrease complication, make them feel better. In high-risk MDS, where there's higher chances of developing leukemia or things of that nature, our treatment options are targeted to extend survival and offer a chance of cure. And we talked about different supportive care treatment options. For patients who have low blood count, who have symptoms, we can transfuse as appropriate. Vaccines, healthy lifestyle, control of other comorbid conditions are important. And then there are specific treatment options, including epoetin, darbepoetin, luspatercept, lenalidomide. Those increase blood counts. So with that, I thank you for your attention. This is Buffett Cancer Center, Chiuli Sanctuary, and I can take any questions. Thank you so much.
Thank you, Dr. Bhatt, for sharing your time and expertise with us today. We will be holding off on questions until after the session with Dr. Dhakal later on today. If you would like to watch this session again later, it will be available on the conference platform in the next hour by accessing the session and clicking on replay or by navigating the on-demand tab in the platform hub. If you are watching online, please take a few minutes to complete the session survey. Your input is important to us and helps us plan for future educational programming. Also, be sure to visit the exhibit hall and chat with the conference sponsors. The next educational sessions will start in approximately 15 minutes. On behalf of the Aplastic Anemia and MDS International Foundation, thank you for joining us today and for making us your resource of choice for information on bone marrow failure diseases. The AAMDSIF Medical Advisory Board and team are here to help you and your family as we have for the past 40 years. This concludes our session.